So let's get back on track and let's talk about parenteral nutrition. This is the preferred method in patients who are unable to tolerate or maintain their oral intake, and maybe there's some reason they cannot have a tube feeding, or it doesn't need to be that long. But parenteral nutrition is totally digested nutrients that are given intravenously, and so they go directly into the circulatory system. The entire GI system is therefore bypassed, eliminating the need for absorption, metabolism, or bowel elimination, as they would know it in the GI system. You will hear this referred to as hyperalimentation. TPN stands for total parenteral nutrition, and then we have PPN, which is partial or peripheral parenteral nutrition. So the formulation for parenteral nutrition varies according to the individual patient's nutritional needs. It's going to have some amino acids, carbohydrates, lipids, and perhaps some trace elements in it. The basic parenteral solution is composed of dextrose, amino acids, and water, and then the other elements are added as needed. Most of the commercial solutions contain a monohydrate form of dextrose that provides 3.4 kilocalories per gram. When we look at the amino acids, we know that the primary role of amino acids is protein synthesis or anabolism. Our amino acids in nutritional supplements can reduce the breakdown of proteins, and also this promotes normal growth and tissue healing. You likely recall the types of amino acids. The essential amino acids, those are the ones that are not produced by the body and thus must be included in our daily dietary or nutritional intake. The non-essential amino acids, those are the ones that are produced by the body, and then the semi-essential. Those are produced by the body, but not in large enough quantities to support rapid growth periods such as those of infancy or childhood. The amino acid crystalline solutions, aminocin 3%, 5%, 10%, and freeamine 3, 8.5%, and 10%, are all a source of calories and protein, and they can be given peripherally or centrally. There are no contraindications for the use of those solutions. So the carbohydrates are usually supplied to the patients through the dextrose. Peripheral parenteral nutrition, or PPN, dextrose concentrations are usually kept below 10% to decrease the possibility of phlebitis. We'll talk more about that in just a few minutes. Central TPN dextrose concentrations can range from 10 to 50%, but most commonly they're 25 to 35%. So these 25 to 35% dextrose solutions have anywhere from a 2.75 to a 6% amino acid, and that depends on the patient's estimated nutrient and water requirements. So their osmolality is in excess of 1,800 millimoles per liter. So this is why they require infusion into a central vein. There are formulas for patients that are without organ failure, and then formulas specifically created for patients who do have organ failure. There is supplemental insulin that needs some time to be given simultaneously with the nutritional supplements, but use of a balanced supplement that contains both dextrose and lipids for the caloric sources decreases the need for large amounts of insulin to be given. So essential is fat, and intravenous fat emulsions serve two functions. They supply our essential fatty acids, and they're a source of energy or calories. When we have essential fatty acid deficiency, this is because those essential here again means that these must be included in daily nutritional intake. We'll frequently see these used with our peripheral nutrition because the peripheral doesn't have that high level of dextrose, so they need to have more energy, more calories for energy. So the additional energy is provided in the form of an emulsified soybean or safflower oil. That's what our intralipid and our lipocin come from. Lipocin, depends on where you went to school. Intravenous fat, these solutions are actually available as a 10%, a 20%, or a 30%, but they are considered isoosmotic. And so they're very well tolerated in the peripheral veins. When the intravenous fat is provided to the patients, the dextrose concentration is actually decreased. And that's what I was talking about in the last slide when I said they could do a balance there between the dextrose and the fats, the lipids, and that allows it to be less need for insulin to be used. So because the intravenous fat is associated with less glucose intolerance, it also is better for the patient in terms of less production of carbon dioxide, less fatty infiltration in the liver, and it's increasingly utilized in patients who have respiratory failure or liver disease with hyperglycemia. So it is good because it especially is helpful in those patients that have large energy requirements. If we look at the next diagram, you'll see, remember this from nutrition, that the various amounts of energy can come from different sources. And remember, fat, we get a lot of bang for our buck. We get 9 kilocalories per gram of fat. So that's why this is being used more and more. This added fat, or this increase in the fat, actually helps those patients because it reduces then the need to have excess administration of the dextrose. And so we can also use the intravenous fat then to help actually prevent essential fatty acid deficiency. The optimal ratio of carbohydrate and fat in the parenteral nutritional support really hasn't been determined, but I think as we move more and more with personalized medicine, obviously nutritional supplementation will follow along and take suit as well. With our parenteral nutrition, peripheral total parenteral nutrition, this is temporary, short-term, usually less than 2 weeks. The dextrose concentration is generally less than 10%. The reason for that is that when we have a higher concentration of dextrose, we see then a 2.75 to 4.25% amino acid. So these solutions have osmolalities that fall between 800 and 1200 osmoles per liter. And this results in, unfortunately, if it's higher than that, we get a high level of thrombophlebitis and line infiltration. So these will provide, again, usually enough protein for patients, but not enough energy with that 10% dextrose. So that's why it has to be a short term. Sometimes we'll even add lipids because they are so well tolerated. Now, the central total parenteral nutrition, this is long-term use, usually over 2 weeks time. So sometimes people will have this for 6 months or longer. These are dextrose concentrations that may be 10 to 50%, but as I said before, commonly they're going to be 25 to 35%. Our peripheral TPN is used to provide nutrients to patients who need more nutrients than their present oral intake can provide. So because this is short-term, we'll see it indicated for procedures that restrict oral feedings, maybe anorexia caused by some sort of treatment, chemotherapy, radiation, GI illnesses that prevent oral food intake, sometimes post-surgical patients, or when the nutritional deficits are minimal, but oral nutrition might not be started for more than 5 days. This is when we'll see peripheral TPN being given. With our peripheral TPN, our adverse effects, phlebitis is the most devastating adverse effect. Phlebitis, it's an inflammation of the vein. Phleb, vein, itis, inflammation. So this is why the lower dextrose solutions are used for the periphery, because those higher concentrations are very caustic to the peripheral veins. Fluid overload can occur due to the osmolality of the solution or because of the inability of the circulatory system to meet the demands of the extra fluid volume. For example, heart failure or kidney disease can increase the risk of fluid overload. So in situations where fluid overload is imminent, PPN may not be adequate in terms of either caloric or nutritional supplements. So the patient will then be converted over to TPN. When we have TPN, we're looking at central TPN, which is delivered through a large central vein. This is usually the subclavian vein or the internal jugular. It can be for long-term use, more than 7 to 10 days. We don't put central lines in one day and take them out the next. And so these are often used as well in the home setting or when we have someone who's going to need more long-term support nutritionally. The disadvantages of the TPN, the central TPN, are the risk associated with inserting the central line, the use of the central line, and maintaining the central line. Because these are central lines and they go directly to the heart, right there in those big vessels, we have a much higher risk for infection, catheter-induced trauma, or metabolic alterations. So when we have problems with these, it's a very serious problem. The central TPN delivers total dietary nutrients to patients who require nutritional supplementation. So these are patients with large nutritional requirements. Maybe they're having some metabolic stress or hypermetabolism. Patients who need nutritional support again for more than 7 to 10 days, or like the patient who is getting PPN but is unable to tolerate the large fluid loads, they would be a candidate then for the central TPN. The contraindications for TPN are, again, those patients with an allergy to any of the components. Rarely, however, it can happen, but it is rare, there can be a cross-sensitivity to some of the lipid formulations in the patient who is allergic to eggs. Our most common adverse effects of central TPN are those surrounding the use of the central line for the delivery, which include infection and catheter-induced trauma. So this catheter-related complication or catheter-induced trauma can result in a pneumothorax, a hemothorax, an arterial laceration, air emboli, brachial plexus injury. This is all during the catheter placement. So you won't be doing those procedures, actually performing those procedures, but you may be assisting with those procedures. So you might see those complications when they occur. The incidence of these complications is inversely related to the experience, obviously, of the physician who is performing the procedure, and it occurs in at least 1 to 2% of the cases, even in large medical centers. And of course, there is a component of this in that we are all anatomically a little bit different. So inserting those devices should be done with a documented chest radiograph prior to the initiation of this, using the catheter. And so we don't put anything in it until we verify the placement of it. And that's pretty standard procedure across the board. Catheter thrombosis and catheter-related sepsis are probably just as important complications of indwelling catheters. These, however, can be as a result of being mishandled. So the patient with the indwelling central vein catheter in whom a fever develops without any other apparent source would have their lines changed over a wire or removed immediately. That central line is not thrown away. The tip of that catheter is quantitatively cultured and antibiotics are started empirically. Then, of course, once the cultures and blood cultures return, the antibiotic therapy is then more specific. So then we have these trace elements that can be added to the formulas. These are based on the patient's needs. This includes this list here. We're going to take one more quick break and come back and talk about are nursing implications.